from the American Academy of Pediatrics.
Resuscitation after drowning is different from other types of resuscitation.
The AAP and the American Heart Association work together to update drowning guidelines.
It's typically those first few seconds to minutes on the scene before medical professionals have even arrived that are most critical.
Plus, new research in the journal Pediatrics shows inequities in the ways families are treated in the neonatal intensive care unit.
The structural racism is really insidious. It is in the laws, in the policies, in our customs. And so this is probably the hardest area to tackle.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about resuscitation after drowning.
Joanna, do you remember the topic of our very first podcast?
Oh, wow. Our very first. I'll never forget. It was with Dr. Ben Hoffman years before he was our AAP president, and it was about drowning prevention.
And it was such a powerful and moving discussion. Well, the AAP just teamed up with the American Heart Association to release a focused update addressing drowning.
You're talking about the 2024 American Heart Association and American Academy of Pediatrics focused update on special circumstances, resuscitation following drowning, and update to the American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care.
That's the one. And today we have lead author, Dr. Tracy McCallum, to talk about it. Dr. McCallum is an associate professor of pediatrics with Case Western Reserve University, an attending emergency medicine physician at UH Rainbow Babies and Children's Hospital, and associate chief quality officer of education at Rainbow. Tracy, welcome.
Thank you, David and Joanna. I'm really excited to be here and appreciate the invitation.
And we're excited to have you. Tracy, we know that drowning is common and tragic. Just how big an issue is this in pediatrics?
It's a big issue. So we know that drowning is the leading cause of death for children 1 to 4 years, and it's the second leading cause of unintentional injury death for children from 5 to 14 years. So it's definitely something that disproportionately affects children over adults. And with some recent statistics from the CDC, in 2021, there were close to 1,000 unintentional drowning fatalities involving U.S. children and adolescents under 20 years in total. Aside from that, there were about 6,500 non-fatal drownings that were treated in the emergency department, like where I work.
I imagine this revision was a huge undertaking. Why take on this project now? Do we have lots of new data?
That's a great question, David. The reason this really was started because we had a precedent with the AAP and AHA partnering together on neonatal guidelines, but have never partnered on drowning. And there have been some recent systematic reviews from ILCOR, the International Liaison Committee on Resuscitation, which prompted this focused update. It was a really awesome opportunity to partner with leading experts from all around the world on drowning, as well as resuscitation experts from the AHA. This was also our first opportunity to have separate publications in circulation as well as pediatrics, where we looked specifically at literature from the pediatric population for that publication. So it really was focused on what the evidence shows for children, separate from adults.
And we mentioned that we've addressed drowning prevention on this podcast in the past, but we've never discussed the chain of survival. Can you tell us what the links are in that chain?
Yeah, so the chain of survival can be thought of similarly to other chains, as people may be more familiar from American Heart, if you have a cardiac arrest or maybe a stroke. The difference with the drowning chain of survival is that the majority of the links focus on what happens prior to the medical resuscitation. So the first link is prevention of drowning. And then the next 3 links focus on recognizing distress of someone in the water, which actually can be quite difficult because it doesn't look how it's portrayed in the media. A person who's drowning has no ability to raise their arms up over their head or yell for help because all the priority goes to keeping their head above the water for breathing. So there's an instinctual drowning response that holds the arms out to the side to try to lift up their head. So that's a really important link. And then the next link is to provide flotation to try to help the person. If you are then able to safely remove them from the water, that would be the rescue link. And then the final link is to provide care as needed if there is a arrest related to drowning and if medical attention is required.
So I just had to recertify in pediatric advanced life support, and I feel like we talked about a little of this, but I feel like there was also a lot missing. What should we as pediatricians know that we don't already know about drowning?
That's a great question, David. I am hopeful that some of this will work its way in now to training materials, since that is the next step after this, evidence-based focus update has come out. One of the most important pieces is separate from all cause out of hospital cardiac arrest, which is often due to cardiac etiology. Drowning is typically a respiratory arrest, which will then progress to a cardiac arrest if it's not interrupted by rescue and resuscitation. So aside from more recent training about hands-only CPR and trying to help, especially lay people understand how to do compressions, the focus on rescue breathing and ventilations for drowning is vitally important. The other good news about this is you don't even have to be PALS trained to potentially save a life from drowning, because the early initiation of bystander CPR from really anybody, you just need to be BLS trained in CPR, can be one of the most important prognostic factors for a good outcome following drowning. So it's typically those first few seconds to minutes on the scene before medical professionals have even arrived that are most critical.
And when I picture rescue breathing or CPR, I picture it on a flat surface outside of the water, but one of the links of the chain is to remove from the water if safe to do so. What if it's not safe? Can you tell us more about in-water rescue breathing?
That's a great question, Joanna, because this is definitely something very specific to this circumstance that is not found in other types of resuscitation training. The in-water rescue breathing is a very specialized skill, and it's not included in traditional PALS or BLS training. This is often a skill that is available for people who are aquatic rescuers, so lifeguards or people who work really in that aquatic environment. And there is specialized training that they would undertake to be able to provide that in-water rescue breathing. The key about it being safe is that sadly, there are a lot of situations where we have a second victim from drowning, when a parent or loved one just instinctually jumps in to try to save a child from drowning and they themselves can't swim, or maybe it's an open water situation and the water is rough or there's waves, and then they become a second victim. So that's why we recommend only if it does not compromise the rescuer's safety to then try to, rescue the person from the water. If the scene is safe and the person is appropriately trained, initiating that rescue breathing in water while moving the person towards the shore is very important. And there is some literature out of Brazil, and Dr. David Spillman, who is one of the world experts on drowning and runs an elite lifeguard group called Sobrasa. They have shown that the in-water rescue breathing can be very beneficial, but they are a really specialized trained group who does so.
In addition to the in-water rescue breathing, this update also highlights the role of automatic external defibrillators, or AEDs, in drowning resuscitation. How are we doing at making those available in the places where they're most needed?
So that was one of the recommendations about PAD programs, public access defibrillator programs. And those currently exist in other places. So where you may have seen that in an airport, a mall, or schools. And currently there's not emphasis on placing those in aquatic environments. One of the reasons is that the vast majority of cardiac arrests from drowning do not have a shockable rhythm. Again, leading back to that initial respiratory arrest, which progresses to cardiac. But in places with high population density, like a water park or a beach, there are cardiac arrests that could occur from a cardiac etiology, like a heart attack, that just happen to be in the water, and that person may then sustain a drowning. So it is important to still have the AEDs available. And we do recommend early application of that in a drowning, as long as it does not delay the initiation of high quality CPR. So especially if you're a single rescuer, the emphasis is on high quality CPR with rescue breathing until someone else arrives to be able to assist with the AED.
Are there special considerations for electricity near water, too? Is that one reason why the uptake of this has not been wide?
That's a really great question, Joanna, and actually something that will need to be borne out a bit more in the literature. We looked at whether we could make a specific recommendation about drying the chest or needing to have that consideration in the aquatic environment. Those had previously been recommendations that did not follow the current evidence-based knowledge chunk format with levels of evidence that the AHA currently follows for their guidelines. So it is something that I think in general people will tend to do, is dry the chest and try to move someone out of lying in a puddle of water. But it is a gap in terms of looking at the medical literature or looking at this in humans outside of animal studies. And so is a planned PICO question for a systematic review when the next revision of the full CPR guidelines come out, since this was a focused update for just the special circumstance of drowning.
And there are so many components to this update that we can't go into detail on, but is there one big takeaway you'd like our listeners to know?
The biggest takeaway is get CPR trained. Bystander CPR can absolutely save someone from drowning or can minimize the sequelae from drowning if they get that initiated quickly. So definitely caregivers, but really anyone. You can, save a neighbor, friend, or someone you don't even know that might be drowning at the public pool or wherever you are. The other really important piece is that drowning is preventable. And so using that multi-layer protection plan against drowning, having barriers in place to prevent the unanticipated access to water, since for that highest risk age group, 1 to 4, almost 70% of drownings occur during non-swim times when children were not expected to be near the water. And swim lessons starting as early as age 1 year with focus on survival skills, water competency is really important.
Well, I think this has all been really important, and I want to thank you, Dr. Tracy McCallum, for talking with us today.
Thank you, David and Joanna.
To read the update, 2024 American Heart Association and American Academy of Pediatrics focused update on special circumstances, resuscitation following drowning, and update to the American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, go to aap.org/podcast.
Coming up, we'll look at inequities in the treatment of families of color in the NICU. David, we have done a lot of episodes about the NICU. I like to think I remind our producer to include our littlest patients.
Oh, I think you're a wonderful advocate for your NICU patients, and some of those episodes have been so impactful in how I practice when I care for NICU graduates or really any neonates.
I thought one of the most powerful episodes we did was on a paper entitled Perspectives on Race and Medicine in the NICU with Shannon Adams. And it was episode 45 of the podcast, so way back in 2021. And at the time, Dr. Adams was a medical student, and now she's a resident at Lurie Children's Hospital in Chicago.
We love to follow up where our guests go, so that's an exciting update for our listeners.
And I do hope Dr. Adams is listening today because a new paper in Pediatrics, The Needs and Experiences of Black Families in the Neonatal Intensive Care Unit, furthers the discussion about racial disparities in the NICU.
Here to talk about it is Dr. Sasha Ondusko. Dr. Ondusko is an assistant professor of pediatrics and a neonatologist at Oregon Health and Science University. She's also the physician lead for the NICU Language Appropriate Trauma Informed Care Group. Dr. Ondusko, welcome to the show.
Thank you. Thanks for having me.
Thank you for joining us today. And this paper is really centered on concepts of reproductive and birth justice. Can you help us understand what those conceptual frameworks are?
Yeah, definitely. So these two theoretical frameworks really guided the work that we did, including from the beginning when we were developing the interview guide and idea for the research project. And really what both of these frameworks do, both reproductive and birth justice, they're about how reproductive rights are human rights and include things like the right to bodily autonomy, the right to have children or not to have children, and the right to parent in a safe and supportive environment. And these movements actually, they have been and continue to be really led by women of color to really call out and stop injustice.
Joanna has undoubtedly had more opportunity to observe this problem than I have, but why do we see racial disparities so commonly in the NICU?
Yeah, that's a really huge and weighty question, and probably deserves a longer explanation than I can provide in like this short interview. But I do work with several neonatology colleagues around the country at different institutions, and we're all working on educational modules to really get at this exact topic. And hopefully it'll be published within the next few years. But really, I think that the question is both easy and hard to answer, but probably the hardest part is about how to change it. I think when we look back historically, we can think about Dr. Kamara Phyllis-Jones and her framework for multi-level racism. And really, race, I hope that we all know, is a societal construct and not based in any science or biology. And yet we see these differences that really shouldn't be there. There's a lot that we know within the maternal realm as well about racial disparities, and that preterm birth is seen at a disproportionately higher rate in Black mothers and Black birthing people. And so we have children who are more at risk for being born premature, and being a baby in the NICU is the most vulnerable physiologic time in a person's life, and adding prematurity to that really just adds on to the vulnerability. But when we think about multi-level racism, and we think about the structural racism or institutionalized racism that people talk about, this is really probably the most important driver, in my mind, one of the most important drivers and the hardest to really navigate. And that really drives the disparities that we see among different racial categorizations, which are probably better termed as inequities because they really shouldn't be present. And the structural racism is really insidious. It is in the laws, in the policies, in our customs. And so this is probably the hardest area to tackle. And then when we think about interpersonal or personally mediated racism, this is the interaction between people, whether it's implicit or explicit. And so this is another thing that comes into play. And both of these concepts are things that really came out when talking with families. But really, to get down to why do we commonly see racial disparities in the NICU, I think we see them throughout medicine. And it's important to continue to look at what their drivers are to really tackle how we can change it and make it better for families and their children.
So let's get into those talks with families that you just mentioned, because this was a qualitative study that relied on interviews and focus groups. How did you make the questions for these conversations?
Yeah, so our research team was a multidisciplinary group. So there were neonatologists, pediatricians, social workers, and then researchers who had a focus on reproductive justice. And so we got together and then partnered with one of the community organizations that it's one of our local community organizations that primarily provide services and care to families of color. And we developed a preliminary or draft interview guide that was guided by the frameworks that you previously asked about, reproductive and birth justice. And when we developed the interview guide, it was really geared towards understanding the lived experiences that these families were having in the NICU. And so with that frame of reference, we developed different questions related to the experiences, the interactions, all of the different aspects of their NICU stay, as well as the recommendations on how we could really improve the quality of care that we're providing. And so after we had this draft semi-structured interview guide, we then established a parent advisory board. So we did recruitment for families who identified as Black and had an infant previously in the NICU. And so we had 3 members on our parent advisory board. And during our first session, this was all done virtually because people kind of lived all over the place. But during our first session, the families shared their stories, their experiences, and it was really an introduction between them and then myself and Dr. Hunt, who's the senior author on the paper and was the one who actually did the interviews and focus groups. And so we did our introductions, and really after that first one where we heard about their experiences, we adjusted our interview and focus group guides. And then in the following session with the parent advisory board is when we did our pilot interview. We conducted a pilot interview focus group with them. And then the families were great. They helped us revise our questions, suggested which ones were no good and which ones were really important to keep. And that's how we came up with it.
And then who did you wind up interviewing in the NICU?
Yeah, so Dr. Hunt did the interviews because she had no previous relationship with any of the families in the NICU. And I felt that was really important because, like you already mentioned, I'm a neonatologist. I may have interacted with the families, and I wanted everybody to feel they could be as honest and transparent as possible during the interviews and focus groups. So we did recruitment for families who had a baby admitted to our institution's NICU between January 2020 and February 2022. And at least one parent had to self-identify as Black. And so we ended up interviewing 9 mothers, 3 fathers, and then 1 grandmother. So a total of 13 individuals. They're from 9 separate families, and then 11 identified as Black.
You organize your results into experiences families had and recommendations for change. Can we start with experiences? What was the NICU like for Black families?
So I was impressed because some of the questions that we asked didn't necessarily get on the topic of what it was like during their actual pregnancy. not an obstetrician, although I really care about their experiences while they're pregnant. This wasn't what the research project was about. But surprisingly, families shared stories about like their entire birth and early parenting journey, and continued to share things even after their baby was discharged from the NICU. And so I'll answer your question, but I'm just going to start by saying a lot of the families did include positive stories and interactions. They also talked about challenging ones, but when they talked about the positives, they often used an example and then they said, and this is what I would recommend in the future. So the way that we organized our experiences and recommendations was really because of the way the families were explaining it to us. So while the families did have some positive experiences, those mostly end up in the recommendation section. But the 5 experience themes that we identified, which were confirmed by our parent advisory board and the study participants during our dissemination events for member checking, included distrust and fear of the medical setting, hypervigilance and trauma trajectory formation, the myth of Black hardiness, policing and surveillance, and then undermining of Black parenting. So I'll start by just talking about the family's experience of fear, because they had fear for their own medical well-being as well as their child. And I have never really been fond of the term mistrust or medical mistrust, because to me it feels like it puts blame on the patient or the parent. And there's a reason that they maybe have made up that they don't trust our system. And it really implies that our system is, in fact, trustworthy, which a lot of these experiences sounded like they counteract that belief. And so every story that they shared that talked about these different experiences with fear or being dismissed or things like that really just reinforced that actually the medical system is untrustworthy and the families are responding appropriately and their outlook on it is also appropriate. And then they give us recommendations on how to make our system more trustworthy, which I think is really helpful and a really huge opportunity for us. The things that made them fearful or really reinforce the untrustworthiness of the medical system were things like missed opportunities to establish trust by being available or sharing information or being very transparent and really actually including the family in the decision making. And then one new area that really hasn't been described in the literature is this hypervigilance and trajectory formation. So the families shared about feeling dismissed regarding their concerns, not receiving information, or being excluded. And that led them to feeling that they needed to monitor the medical team more. And that continued even after discharge. And I think that really shows us that these early experiences with the healthcare system can inform and influence future interactions. And so again, we have a really big opportunity and we should encourage and be receptive to parents' advocacy attempts. And some of the other things that families talked about experiencing were observing differences in treatment, the amount of surveillance that they felt they were under compared to others, and the way the policies were implemented. And they often felt they were having their parenting role undermined and just really recommended that families be viewed as a unit and really engaged and included and helping to facilitate the bonding and attachment with their child.
Well, as a neonatologist, I'm so grateful that these families shared this with you. And you had mentioned they gave recommendations as well, suggestions for improving care. Can you share some of those?
Yeah, definitely. So parents had a lot of recommendations, and it was really exciting because it has helped us make big changes and little changes in our NICU. But the way that we organized it, I'm hoping will be helpful for other NICUs to think about. So they recommended for healthcare providers to really work towards earning families' trust. And the way to do that is communicating frequently and allowing for shared decision making. So this concept of not withholding information. So not all families, I acknowledge, will want the same amount of information, but the families really told us the families should be the ones to decide how much is too much and would let us know. Other recommendations felt more in line with what unit leaders should do. So developing universal protocols to share resources and also increasing access to mental health support was another big area of recommendation. And then at the institutional level, really diversifying the healthcare workforce and making sure staff are educated about cultural humility and different lived experiences to try to decrease biased treatment.
Well, Dr. Ondusco, we want everyone to read this powerful paper, but before they do you have any last takeaways for them?
Yeah, I think one big takeaway, which we get at in the introduction as well as the discussion section, is that while we've added to the literature in several important ways, our results overall are not unique to our location. And so there have been numerous studies, testimonies, news reports, books from many different units and geographic regions in the country that have discussed really similar issues of differential care and access related to race. And this issue can be really hard to think about. How do I change? How do I improve my NICU? And I hope that by reading this paper, people being providers, staff, everybody part of the medical field, can have some real actionable items to be able to address this. And for our NICU in particular, we've started new initiatives, programs, and research projects based on the recommendations of families so that we can continue to work towards becoming more equitable for families and a more just medical home for them and a place that communities can trust. And so some of the things that we have been working on is really orienting the families better to the NICU, because a lot of that early, how do you want to be communicated with, is really important to assess with every family. And so we do a NICU orientation for families now. And I think there's been improvement with I haven't done another needs assessment, but I think that I've seen that there's been improvement with how the families are receiving new information and how they're being communicated with. We've started peer support groups that are racially, ethnically, and linguistically matched to try and help some of those feelings of isolation and the discordance with their providers and help with forming community for them. And those also address the mental health aspect, because we have mental health providers who come to facilitate those peer groups. And so there are so many opportunities to really think about what is offered in your NICU and how can we all improve the quality of care that we provide.
Dr. Ondusco, thank you so much for sharing this work and for joining us today.
Thank you.
To read the paper, The Needs and Experiences of Black Families in the Neonatal Intensive Care Unit, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what is your Say Ah this week?
I'm coming off of time spent with all of our kids, and the lingering one is Sellers, who's going back to finish his senior year. But before he does, we're doing nature walks around the neighborhood, which is one of my favorite things to do with anybody. And we currently have a pair of hooded mergansers in our little back pond. If you're going to have to look that up. I recommend Cornell's Merlin bird site, but they are extraordinary birds. They look like they have a mohawk, like they're like punks from the 1980s, and yet also ducks.
I'm not surprised that your Say Ah is about birds.
I know.
I'm going to make mine about books.
Oh.
I am reflecting on all the generosity of friends and family and the gifts I got this holiday season, and my very favorite gifts are to get books. And so I'm currently reading a historical fiction novel that my mother gave me for the holidays, and I'm really enjoying it. And it's Brooklyn, by the way. I think there's a TV show about it and other things too. And I'm just so grateful coming into this year to have these gifts from friends and family and to be able to read all of these different books now on my shelf. That just fills me with such joy.
I love that. I'm going to pass it on to my wife, Christy. I know you guys talk about books offline and have similar tastes, so that may already be on her list. In the meantime, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at the non-medical use of controlled substances by youth and adolescents.
We'll talk to the lead author of a new clinical report, Dr. Nicholas Chatty. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Balinki. Thanks for listening.